Thank you very much for joining us today. My name is Dr. Michael Ruma from New Mexico. I work for Perinatal Associates. I'm happy to have you join us today for a presentation on fetal infections, diagnosis, management, and outcomes. I really appreciate your willingness to spend some time today with us. I would like to thank you on behalf of Philips for all of your diligent work throughout the COVID-19 pandemic. We're going to discuss a variety of fetal infections today, and I'd like to utilize a couple of ultrasound-based cases in order to really illustrate the importance of how we should manage these cases. So, fetal infections, diagnosis, management, and outcomes. A few brief disclosures about myself. First and foremost, I'm a private practice maternal fetal medicine specialist in Albuquerque, New Mexico, and I work for Perinatal Associates in New Mexico. I also do some outstanding work with a few companies, Hologic, CCSI, as well as our friends at Philips Ultrasound. I grew up in Omaha, Nebraska. I did my medical training there at Creighton University, residency in OBGYN, went on to fellowship training in Chapel Hill, North Carolina, and landed in New Mexico for the last 13 years. Our practice is a large one in the state, founded in 1987. We have 4 physicians and 100 team members that help us take care of a large number of obstetric patients throughout the state. We use a lot of Philips ultrasound equipment, currently using 25 different Epic Elite systems and a fair number of portable systems to help throughout our hospital-based services. We do a lot of antenatal monitoring and have done a dramatic amount of telemedicine work using a tool called Collaboration Live throughout the COVID-19 pandemic. We're a large practice doing over 30,000 ultrasounds throughout the state. We do a significant amount of antenatal fetal testing as well. We're accredited by the American Institute of Ultrasound and Medicine in all things obstetric, as well as in fetal echocardiography. We're definitely a leader in the southwestern portion of the United States, and we've had a significant amount of experience doing research with Philips on pre-release equipment, software, as well as validating new products that are going to be shared with all of you. All right, so that's just a little bit about myself, a little bit about our practice. I really appreciate the opportunity to join you, and let's talk a little bit about fetal infections. You have to start with TORCH infections as a brief overview. So as we know, infections acquired in utero can lead and be a significant cause of fetal and neonatal morbidity and mortality. And unfortunately, that infected fetus can demonstrate growth abnormalities, some developmental delay, or clinical and lab abnormalities after birth. Classically, TORCH, perinatal infections, T for toxoplasmosis, O for other, R for rubella, C for cytomegalovirus, and H for herpes, is really what we're classically taught. This other category, the O, has been significantly growing over the years, including varicella zoster, parvovirus, hepatitis, listeria, enterovirus, HIV, Zika as well, and unfortunately right now, COVID. We do prenatal screening for TORCH infections, at least in almost most of our prenatal packages across the world, but there is significant variation geographically across the globe. In the United States, at the first prenatal visit, we definitely evaluate patients for syphilis as well as for rubella infection. And there are some states in the United States that do toxoplasmosis screening, but outside the United States, that screening on the prenatal package is actually relatively common. Asymptomatic infants are not routinely screened, interestingly. We do some screening in European countries and a handful of United States circumstances looking for toxoplasmosis in the sense of universal screening. You can go to these websites where we can evaluate where these infections are looked at by state. And interestingly, in the United States, we tend to only evaluate for CMV infection if those infants fail newborn hearing screens. Fetal infections really pose a dramatic problem for us as maternal fetal medicine specialists because we have 2 patients. You have maybe a patient, the pregnant woman who's infected, and then the developing fetus that stands the risks of these types of infections. Every type of in utero infection, we have to consider the actual rate of transmission to the fetus. How do we go about diagnosing that fetal infection? And then are there any interventions that we can do to actually prevent and treat those fetal infections? And then after delivery, how do we notify the pediatricians so that we can diagnose that infection in the newborn? And then what is the postnatal management in that newborn? Unfortunately, these infections also stand and pose significant risk in the sense of miscarriage in the first trimester, stillbirth in the second and third trimester. The more common one that we encounter as obstetricians and maternal fetal medicine specialists is fetal growth restriction. This can be very early on. It tends to be very severe under the third percentile. It is posed as this symmetric fetal growth restriction picture so that the entire parameters, all of the estimated fetal weight parameters, are abnormal. And then there are usually some associated ultrasound features like echogenicity in the liver, calcifications in the fetal brain, or the more classic and very dramatic one, that of hydrops or fluid collections, be it in the skin, in the chest, in the abdomen, all that point towards some problem with non-immune hydrops. There are a variety of fetal ultrasound abnormalities associated with intrauterine fetal infection, and those range from ventriculomegaly, problems within the ventricles, adhesive disease, intracerebral calcifications, actually a small fetal head, microcephaly, where we have this kind of subjective finding, echogenic bowel in the intestines, maybe meconium peritonitis is yielded from an intrauterine infection, a whole host of fetal abnormalities. Other things like ascites, those pleural and pericardial effusions that may be associated and add together to a picture of fetal hydrops. And then more commonly, actually, we may see no findings at all until birth. That's a bit of a background about TORCH. Let's move on and talk and utilize a couple specific case-based discussions to further our interest in fetal infections. And I'm going to talk primarily about two different infections. And the reason I've chosen these is that they become really the most common that we as obstetricians and maternal fetal medicine specialists are going to encounter. So take this first case. She's a 26-year-old gravida 1 para 0. She's 26 weeks and 3 days, and she comes to MFM ultrasound clinic for an evaluation. She tells you that she works in a daycare, and unfortunately, two children within that daycare have been diagnosed with parvovirus. And here you see the classic slap cheek appearance on a child, a lacy reticular rash, which is really classic for that parvovirus infection in a child. So how do we go about confirming with that patient? That would be rule number one, is we need to define, is her contact significant or not? 50% of women are not immune to parvovirus and ultimately are susceptible to infection. And so significant contact is kind of similar to what we've experienced throughout the pandemic, is being in the same room for greater than 15 minutes with that individual or very significant face-to-face contact. And parvovirus is in general highly infectious prior to the onset of the rash in that child. It's a respiratory transmission similar to COVID or direct hand to mouth contact. Its incubation is pretty short, 4 to 14 days. And the person that shares that infection with the pregnant woman tends to do that 5 to 10 days prior to the onset of that lacy reticular slapped cheek rash. Once the rash has appeared on the child, ultimately that child is not infectious at that point. Highly infectious with 50 to 90% of household contacts becoming infected. How do we go about confirming this infection? We do that by drawing serology, IgM and IgG for parvovirus. That can help us determine a prior infection, her susceptibility, or an actual acute infection. I'd really encourage anyone that is approaching a fetal infection to really lean on algorithms to guide your management and evaluation. We want to look at the parvovirus serology. If the patient is IgG negative and IgM negative, the left-hand side of the column, we want to repeat both of those titers within 2 weeks. If they are indeed both negative, we then want to move on because she is not infected. If she has an IgG positive test and an IgM negative test, we then want to move towards maternal serum parvovirus PCR to evaluate if she has an acute infection. Were she to be IgG negative and IgM positive, that definitely is indicative of an acute parvo infection. So this indicator, the IgM parvovirus, is highly suspicious and the fetus is indeed at risk of an infection. Additionally, if she's IgG positive and IgM positive, that also is indicative of an acute parvovirus infection, and the fetus is at risk and needs important follow-up in utero. So in this patient's case, the patient's IgM is positive, her IgG is negative. So she has an acute marker serologically of infection, and she's diagnosed with an acute parvovirus infection. What do we counsel this patient on? We need to tell her that there is a significant risk of vertical transmission, 15% early in the first trimester, 25% after 15 weeks, and at term is highly transmissible up to 70%. Fortunately, in these circumstances, significant damage to the fetus is rare. Fetal hydrops only occurs in about 3 to maximally 10% of all acute parvovirus infections during pregnancy. And the IUFD, or stillbirth rate, in this setting is quite low. If the infection occurs less than 20 weeks, it's slightly higher. It's extremely rare after 20 weeks, though, to have any significant damage to the fetus. How do we go about following this patient? So she's had an acute parvovirus infection. We know that that patient has a risk because parvovirus B19 can cause fetal anemia. That is one of the main mechanisms that it damages the in utero fetus. And so, as she presented at 26 weeks and 3 days, we would want to do middle cerebral artery peak systolic velocities using this type of Doppler evaluation. Ideally, you want to interrogate the MCA that's in the near field in the ultrasound, get these sharp, crisp peaks, and measure that peak systolic velocity. And then I'd ask you, do we think that this is a normal evaluation? So what we need to do is take that peak systolic value and then determine, is that appropriate for that fetus at this gestational age? I'm a big fan, I told you, of algorithms. I think they're incredibly helpful. This is a wonderful website from where I did my fellowship training at the University of North Carolina in Chapel Hill. They have an extraordinary website called mombaby.org that provides an inordinate number of obstetric algorithms for treatment of complicated patients. And I commonly utilize this for a reminder of how to approach these patients. So we want to look with the MCA Doppler peak systolic velocity every single week in order to identify fetal anemia, and ideally do that for at least 10 and up to 12 weeks maximally. Using Doppler ultrasound, something we're highly accustomed to in our field, is 100% sensitive to detect and predict fetal anemia in the setting of an acute parvovirus infection, so incredibly useful. And we know that from a study done many years ago by Del Chai in ISUOG, which demonstrated that there was a very high sensitivity for detection of anemia, as well as a very high positive predictive value, actually greater than the detection of anemia in the setting of red blood cell sensitization. So a tool that we can rely on to predict problems in the fetus in the setting of an infection. If we detect severe fetal anemia, then we need to move on with a periumbilical blood sampling and an intrauterine transfusion. This is a graph of what we would do, and I would encourage you to plot these out each week. Looking at the bottom line is the 1.0 multiples of the median, then the 1.29 indicating moderate anemia, and then the 1.5 multiples of the median indicating severe anemia. When we exceed that level, that is when we need to do some sampling of the fetal umbilical vein to determine if there's an anemia present. The calculators are readily available throughout the globe. Perinatology.com is a significant resource. This is the calculator expected peak velocity of systolic blood flow. And you would simply plug in the patient's gestational age, put in the mean peak systolic velocity, and click calculate. In this patient, you can see that the mean systolic velocity is significantly elevated at 1.6, and that she would need some in utero investigation. So this case, mild to moderate anemia, we know is well tolerated by the fetus. If at any time there's a severe anemia, we definitely need to assess the fetal hematocrit by using PUBs. And we can tell the patient confidently that fetal intrauterine transfusion in the setting of anemia or hydrops dramatically improves the survival rate and the outcome for the fetus. In a study, von Keisenberg, again published in UOG in 2001, when we did a transfusion, 82% survival was reported. If we did not, only 55% of those fetuses survived. And the resolution of severe fetal hydrops takes about 6 weeks after an intrauterine transfusion for an acute parvo infection. All right, so That's parvovirus, something we should all know about, most common in the spring. And we need to know how to work that up as a maternal fetal medicine specialist. Here's another case. 30-year-old G2P1001. She's 20 weeks and 2 days. She comes to you for an evaluation again, and she tells you that she's a neonatal intensive care unit nurse, and she's been exposed to an infant with active cytomegalovirus, or CMV. And here's a characteristic picture, kind of a blueberry muffin rash in the baby, a very significant, striking disease. Ultimately, this patient is significantly concerned about her risk of developing in utero CMV. We need to know that CMV is by far the most common congenital infection. It has an incidence of 0.2 to 2.2%. It is something you may encounter. 50 to 70% of women have had a prior infection with CMV, demonstrating IgG positivity. But unfortunately, there are a variety of serotypes for CMV, and primary and then ultimately recurrent reactivation infections can lead to fetal infection. The primary infection, though, often is asymptomatic. Patients hardly notice the mild malaise, lethargy, or a low-grade fever. But CMV IgG positivity tends to come 2 weeks in a primary infection, and that sticks around lifelong. For this patient in particular, we need to confirm her status, again, like parvo, drawing CMV, IgM, and IgG. For her, her IgM is also positive, her IgG is negative, and we definitely suspect an acute primary CMV infection. When we see a positive IgG, we want to repeat that after her suspected exposure. Indeed, she's turned her IgG positive, so we have a significant suspicion of an acute infection. To confirm this acute infection, we use avidity testing for that IgG, and her avidity testing was low, indicating that the antibody is new. It has yet to be very, very strong in its response to exposure to CMV, and most likely this is a primary maternal infection. Our vertical transmission risk is low, 40% in the first trimester, but in the third trimester can be up to 80%. We would like to recommend confirmation by amniocentesis for CMV PCR in the amniotic fluid, but you need to delay this evaluation until 6 weeks after maternal serum positive testing. The risk of harm is significant. A fourth of these fetuses are infected and can be problematic at birth. This is, again, another algorithm. I won't detail it, but from University of North Carolina's mombaby.org website. This is detailing how to manage the positivity of the PCR. Here's our evaluation. We can see the fetus present in this video. There's definitely fetal growth restriction, microcephaly, there's ventriculomegaly present, and in this case, what I'm showing you is echogenic bowel. None of these features are diagnostic, so we really need to lean on confirmation by invasive fetal testing. She elected to proceed with an amniocentesis, and we did do that 6 weeks after her exposure at the time of that echogenic bowel finding. Interestingly, we found that maternal antiviral therapy may be useful in this setting, and that's new information. IVIG has been explored significantly, but has not been shown to have dramatic effects. Recently, in very recent history, in 2016 and 20, in American Journal of OBGYN, Valtrex 8 grams daily significantly increases the proportion of asymptomatic neonates compared to no treatment, 43 versus 82%. So this is a first study reporting an efficacy of a drug taken by a mother to reduce in utero fetal effects. In another study in 2020, small 12 pregnant women treated with 8 grams daily of valcyclovir after a maternal CMV diagnosis was confirmed by amniocentesis. You have to treat these patients until delivery. The transmission rate to the fetus, though, was ultimately reported at 17%, which is a huge 50% reduction from the historical reported rate of about 30 to 40 vertical transmission rate. So this is the first series of an antiviral treatment in women with CMV prior to amniocentesis. There's also prospective studies on IVIG, and unfortunately, this randomized controlled trial never demonstrated a benefit of prevention of infection of fetal CMV, unfortunately, making us think more that we need to rely on valcyclovir and hopefully study that significantly more. Yet another study done by the MFMU, no difference in IVIG treatment for moms that are infected with CMV. To close, there's a significant amount of research about fetal infections, the damage that they can cause to in utero fetuses, but there really is a lack of experience and research about the parents who experience a fetal diagnosis. And hearing about a fetal diagnosis from obstetricians and maternal fetal medicine specialists like ourselves can be acutely distressing to patients. We need to provide them accurate information. It's incredibly important, and we need to make sure that we refer these patients to appropriate subspecialists so that they can receive excellent treatment for the infections that their fetus may be at risk for. I greatly appreciate the opportunity to talk to you today. I'd be happy to answer any questions. And if you'd like to reach out to me, please feel free to reach out to me to these 2 emails. Thank you very much, and I hope you have a wonderful rest of your day.
Hello, everybody. I am Professor Joanna Dangel. I am pediatric cardiologist and the pioneer of fetal cardiology in Poland and the head of the Department of Perinatal Cardiology and Congenital Anomalies in Warsaw, Poland, which is the biggest department referral center for fetal cardiology in Poland and one of the biggest in Europe. Fetal cardiology started from fetal echocardiography, and the pioneers were Lindsay Allen and Charles Kleinman. And since 1990, it was the screening for looking at the heart by obstetricians that it changed a lot in fetal and pediatric cardiology. So starting with this, we have to understand the fetal cardiovascular system, in which we have the placental connection of the umbilical cord, fetal connection, and the ductus venosus, which is the very important part, as in this way, the whole oxygenated blood is entering the right atrium, left atrium, and left ventricle, and then the higher oxygenation blood is getting to the aorta, and lower oxygenation blood to the descending aorta through the pulmonary artery. This is very important for understand the fetal heart defects, and we must remember that we are not looking for the fetal heart through the keyhole, as we have to do the fetal biometry, evaluation of all flows, other organs which are important for heart defects, and of course segmental analysis and morphology and function of the whole cardiovascular system using cardiovascular profile score. The important is to plan the care of the fetus with congenital heart defect. So we must answer the question, what kind of congenital heart defect is this? Is that a high risk for genetic problems? Is that the ductal dependent lesions, and how can we predict it? And is that the risk of changing the pathophysiology of this defect? How often we should repeat fetal echocardiography, and when the last fetal echo should be done before delivery? And just 3 big groups of heart defects: mild to moderate defects, which usually will not have to be operated on during neonatal period, and the fetal and the neonate should be in a good condition. It's VSD, atrioventricular septal defect, tetralogy of our mild pulmonary and aortic stenosis. Critical fetal heart defects, in which there is a high risk of fetal heart failure, like Epstein anomaly or common arterial trunk with dysplastic valve. This is the pulmonary lack of pulmonary valve, which is one of the very important lesions as well, leading for fetal heart failure. And all ductal-dependent lesions in which prostatin will be important for the neonate, but they should be in good condition after prostatin giving. So starting from the most common congenital heart defect, VSD, every week we have at least few suspicion of perimembranous VSD in the fetus. Does it really important if we find it or not? Let's show you the example. This is the missed VSD in the fetal life, and it was recognized in the baby because of the heart murmur. The baby was operated on when she was 13 months of age without any problems. So what is the matter? That this defect was missed in the fetus like this. You can see this VSD. No, it didn't. But sometimes it really did, because if you see such a big inlet VSD, with some other symptoms like the fetus is small for gestational age. These are ultrasound markers of trisomy 18 and other signs of trisomy 18. Counseling is important as the heart defect is benign, but the general fetal defect is lethal. So it must be important to introduce the perinatal palliative care, and we wrote the standards of this, which are exactly the same as the statement of the American College of Obstetrics and Gynecologists about the perinatal palliative care. I think that this is important because we were one of the pioneers. Then the other thing is the position of VSD, which is important because if there is the perimembranous VSD, it doesn't matter. But if the VSD is subaortic or posterior malalignment, it causes the problem. So the great artery is developed according to the volume of flow, so the volume which is flowing across the VSD. The most common is subaortic VSD, which is characteristic for conotruncal defects like tetralogy of Fallot. Here you have the small pulmonary artery, but with normal flow from the right ventricle to the pulmonary artery. And this is the other defect in which you have the higher angle of the fetal heart and the very narrow pulmonary artery. And here, turbulent flow across the small ductus arteriosus of the arthritic pulmonary artery. So in both situations, different decisions, as in tetralogy of Fallot, most probably it will not be ductal dependent defect and the baby can be delivered anywhere, but mandatory will be the cardiac consultation in a neonatal period. However, in tetralogy of Fallot with pulmonary atresia, which is certainly ductal dependent lesions, the baby must be delivered close to the cardiac center, but condition of the baby should be stable and prostin. And we have to remember about the risk of the microdeletion 20^11 in both of those lesions. Then tetralogy of Fallot is one of the very well follow-up lesions. These are pioneers of pediatric cardiology and cardiac surgery. It was the first operation for tetralogy of Fallot, Blalock-Taussig shunt. And here is one man who is the Olympic champion in snowboard, the boy after this operation. So you must remember that this is really the defect in which the follow-up is very good and the results of operation are good. Then in posterior malalignment VSD, which is quite tricky because in the fourth chamber it doesn't sin, it's left to right shunt through the VSD, and here is the interrupted aortic arch. So not VSD is important, but interrupted aortic arch is important, completely different consultation. Then transposition of the great arteries, situation in which we can really save the baby's life because after delivery, there is completely separate flow with unoxygenated and oxygenated blood, which is entering to the pulmonary arteries. What is important during the fetal life? Important is the flow across the foramen ovale and the ductus arteriosus. Like this is very, very little the reverse flow in the ductus arteriosus. And here it is very normal flow across the foramen ovale, unrestricted, but it can be restrictive, close to delivery like this. And in such situation, the baby needs the very, very quick Rushkin procedure. And each treatment has a adverse effect. This is the fetus with transposition in whom after steroids and atosiban in 32 weeks of gestation, it was complete closure of arterial duct. And then the baby was born with very, very severe pulmonary hypertension. It was emergency Rushkin due to secondary ductal occlusion, very big pulmonary arteries, and unfortunately, it was unreversible pulmonary hypertension in the newborn. So decisions in transposition is important that it is not genetics necessary, as this is isolated defect, normal fetal growth, and increased pulmonary blood flow at the end of pregnancy can cause the foramen valve closure after 30 weeks of gestation, even if it was widely open before. And then hypoplastic left heart syndrome, very commonly recognized before delivery as there is abnormal for chamber view. With the hypoplastic left ventricle from the early pregnancy, we have to look at the pulmonary veins because such a pattern of the pulmonary veins cause a very high risk of for the neonate. But we can have the evolving hypoplastic left heart syndrome, which started from severe aortic stenosis, in which we can consider the fetal ballooning valvuloplasty in this situation. It didn't work because the left ventricle didn't grow. In this one, it was a very good effect, and the baby didn't need any surgery until now it's 3 years old. The other thing in the hypoplastic left heart defect is the middle cerebral artery flow, in which pulsatility index is lower, and it is normal for fetuses with hypoplastic left heart syndrome. So this is decisions in hypoplastic left heart in classic. We should do microarray, we should counseling according short and long-term outcome, which is much better now than it was before. And we should follow up the foramen valve flow and pulmonary veins, function of the right ventricle and the size of the ascending aorta and size, and try to deliver the baby at term and no necessity for cesarean section. In evolving, it's very important decision if this fetus will benefit if we open the aortic valve. Are we sure that we have good criteria? And is that really possible to change the natural history? And at the moment, it's a difficult way to prepare the baby for the further follow-up. So it is very important to cooperate closely with pediatric cardiologists and cardiac surgeons. So to prove that children with hypoplastic left heart syndrome can have the fantastic life, I'd like to show you the baby whom I met first time in 24 weeks of gestation. He was operated on having a very little aorta, and at the moment he is 19 years old boy after a high school graduation going to the university. So I hope that basing on my presentation today, you will believe that children with congenital heart defects can have a very successful and nice life, and that cooperating together, you as obstetricians and we as pediatric cardiologists can really give our patients better and happier life. Thank you.
Welcome to this session. My name is Basky. I'm the Professor of Fetal Medicine at St. George's Hospital in London. I'm grateful to Phillips and Dolores Cantelli for the invitation to give this lecture on the placenta and preeclampsia, whether it is the villain or the victim, and really about the role of the maternal heart in the development of preeclampsia. It's a commonly held belief that the placenta causes preeclampsia. And in this diagram, we show that the placenta and abnormalities of placentation can lead to the syndrome we recognize as preeclampsia, which involves hypertension, proteinuria, and some organ dysfunction that is well characterized and has been characterized for over 100 years. The problem with this hypothesis is that it assumes the placenta as an organ in isolation and does not really account for the fact that the placenta is an organ of perfusion, and that in order for the placenta to work, it requires a maternal cardiovascular system to pump blood through it efficiently. And it is this exchange of blood that leads to the placenta's ability to perform multi-organ functions, for that of the lung, for that of the kidney, for that of the metabolic system, etc. And it is possible that we have mistaken maternal cardiovascular dysfunction for placental dysfunction in the etiology of preeclampsia. And therefore, the theory I wish to put forward to you and for you to consider is the possibility that instead of preeclampsia being a consequence of primary placental maldevelopment, which is what we are led to believe in terms of uterine artery transformation or lack thereof, that it is possible that preeclampsia is a consequence of chronic placental hypoperfusion due to maternal cardiovascular dysfunction. So how do we go about investigating this? The first thing to do is to say, well, what is maternal cardiovascular function like before a woman gets pregnant? And there are now several studies to show that maternal cardiovascular function is poorest in the women that subsequently develop preeclampsia and growth restriction. And that inferiority or that deficit of maternal cardiovascular function is pre-pregnancy. There's a very study by Fu and colleagues that looked at several hundred women who wished to get pregnant and showed that the women with the poorest hemodynamic indices pre-pregnancy, the women with the poorest cardiac outputs, the highest mean arterial pressures, and the highest vascular resistance were the ones that were likely to develop preeclampsia and FGR. So we now know that pre-existing heart disease, even if it is occult and not an overt disease, predisposes significantly to preeclampsia. What about maternal cardiovascular function before and during the pregnancy, before the development of preeclampsia and when preeclampsia is diagnosed? Well, the studies show that women who develop preterm or early onset preeclampsia had the worst kind of pre-disease cardiac dysfunction. So several weeks, if not months, and usually at around 20 weeks of gestation, it's very evident that these women have left ventricular remodeling, diastolic dysfunction, abnormal hemodynamic indices, and also volume deficits. For women who develop term preeclampsia, there is also at mid-gestation increased chamber filling pressure and increased left ventricular mass index. And there is now several papers to show that these cardiovascular deficits precede the pregnancy, not only before the pregnancy, but precede the development of preeclampsia itself. Now, how about cardiovascular function when the diagnosis of preeclampsia is made? And here is where an explanation to an obstetric audience may be useful, because I've used lots of terms. Cardiovascular function can be broken into three sort of parameters. One is hemodynamic function, which is looking at things like cardiac output and vascular resistance. The second is myocardial function. That means looking at the muscle itself and seeing how well the muscle works. And then finally is chamber function, which is how the chamber overall is a sort of overall assessment of heart function. Now, in preeclampsia, hemodynamic function is absolutely compromised, and it is typically a high resistance, low output circulation. Many of you may have read or may have been led to believe that there are two versions. There's a high resistance, low output type of preeclampsia, and there is also a low resistance, high output type of preeclampsia. And that is a misinterpretation of the data. All women who have preeclampsia have high peripheral vascular resistance. There is no low peripheral vascular resistance preeclampsia, and you know that. They are hyperperfused. Their peripheries are badly perfused. And the reason for the misunderstanding is that the resistance and cardiac output is expressed as a baseline of non-pregnant women, when what they should be doing is looking at the resistance and output of circulation relative to pregnant women at the same stage of pregnancy. And if you were to consider that, then all preeclampsia is high resistance and low output. In terms of the myocardial function, there is diastolic dysfunction, which is this the heart being unable to relax, or the heart muscle being unable to relax adequately. But the most profound changes are related to what's called ventricular remodeling. That means the geometry of the heart, how the heart is structured. And what happens in preeclampsia is that the heart becomes overly thickened, yes, due to pressure overload, and overly dilated due to volume overload. And that the severity of this dysfunction is worse in the preterm cases compared to the term cases. Now, there should be some allusion to the epidemiology of preeclampsia, because after all, it's the epidemiology of preeclampsia which led us to believe the placenta was the culprit. And if we re-examine the epidemiology, then a different pattern appears. which is that you all recognize many of the risk factors presented here: advanced age, obesity, ethnicity, SLE, ovarian failure, diabetes, etc., etc., etc. Now, we have all been led to believe that these risk factors directly somehow affect the placenta. Somehow the placenta knows how old the mother is or what ethnicity is and decides to develop poorly. What I'm going to present to you is an alternative, which is that every single one of these risk factors is a known and established risk factor for heart disease. And perhaps it is much more rational and much more reasonable to say that the mechanism by which all of these risk factors predispose to preeclampsia is that they affect maternal heart function and are detrimental to maternal heart function. Yes, the older one is, the more obese one is, the more likely you are to have poorer heart function. And that poorer heart function leads to chronic malperfusion of the placenta and therefore damage to the developing placenta. So let us not look for how these factors may directly affect the placenta, but let us assume, or let us certainly understand, that these risk factors are well established in cardiovascular medicine. Now, there are some epidemiological explanations that defy a rational explanation. So, for example, it has been proposed, and these are the commonest, is that parity and that nulliparous women are more likely to get preeclampsia. And that has some sort of immunological basis, that the nulliparous woman hasn't been exposed to the father, and that's why she developed preeclampsia. And this is an immunological basis hypothesis, and it alludes to the fact that there may be reduced immune tolerance. And that's backed up by the fact that ovum donation is also a predisposing factor to preeclampsia. Well, the explanations are much more rational, which is that when a heart, when a multiparous woman has gone through a pregnancy, that heart function improves several percent, about 10 to 15%. So a woman who's had her first pregnancy has improved heart function in subsequent pregnancies, and therefore less likely to underperfuse a placenta, and therefore less likely to develop preeclampsia. So pregnancy is a type of conditioning. It's a type of training. In the first pregnancy, the mother's heart undergoes a lot of changes, which make it much better at coping with a subsequent pregnancy. So actually, this is a recognized concept of preconditioning in cardiology, and parity actually is a conditioning mechanism. It helps the heart cope better with a subsequent pregnancy. But of course, in the first pregnancy, some women don't cope with it and they develop preeclampsia. So getting your first pregnancy protects you from subsequent pregnancies, not through an immunological basis, but because it improves your cardiac function. Now, Eastern Bloc countries realized that 20, 30 years ago, and very topically at the moment as I record this presentation, the Olympics are on. And it is well accepted that long-distance athletes, female long-distance athletes, used to be recommended to get pregnant before they got back into training, because that improved their long-distance elite endurance. Ovum donation indeed predisposed to preeclampsia, and that alludes itself more to a decidual immune tolerance issue. The only problem is everyone overlooked the fact that ovum donation is undertaken in women with premature ovarian failure. And that premature ovarian failure usually occurs because of mosaic Turner syndrome. So both premature ovarian failure, with or without Turner syndrome, and mosaic Turner syndrome are again established risk factors for heart disease. Yes, so when a woman has premature ovarian failure, her risk of heart disease increases. Now, there are other things like a new partner, IVF, and cohabitation, and they were also assigned to an immunological hypothesis. But actually, the latest and the largest epidemiological study shows that new partner, IVF, and cohabitation are in fact statistical confounding. Once you correct for these associations, for example, a new partner, the woman's older, yes, the IVF, the woman's older, et cetera, then you find that those associations disappear. So a new partner and IVF are not risk factors for preeclampsia. Ovum donation is, but only because women tend to have premature ovarian failure and increased cardiovascular disease. So how does all of this fit in with screening and therapy in preeclampsia? We are all aware now from the ASPRE study published in 2017 by Kypros Nicolaides and the King's Group that the best available test for screening is the first trimester combined preeclampsia test. Now, that test involves medical history and the risk factors we've already covered as being cardiovascular risk factors, age, ethnicity, obesity, diabetes, etc. It also involves measuring blood pressure, and blood pressure is a cardiovascular marker, not a marker of the placenta. And uterine artery Doppler, as shown here on the right-hand side. Now, we used to believe that uterine artery Doppler is a marker of placental function because it's measuring the blood flow to the uterus and placenta. But what we know now from several studies is that ophthalmic artery Doppler of the mother is as good as uterine artery Doppler in screening for preeclampsia. And ophthalmic artery Doppler changes cannot be related to placental development. Yes? And therefore, the assessment of this is that both uterine artery Doppler and ophthalmic artery Doppler are assessing or measuring maternal peripheral cardiovascular function and perfusion. And they are a generic marker of maternal cardiovascular function. And it is that assessment that is used to look at the risk for preeclampsia. Now, you might say, aha, PLGF, placental growth factor, that's coming from the placenta. It's definitely a marker of the placenta. Indeed, it comes from the placenta. In fact, it comes from all of the endothelium in the mother, and the majority of PLGF is produced by outside the placenta. But what is important here is not what the name of the hormone is, PLGF, placental growth factor. What is important here is what does PLGF do biologically? Well, the function of PLGF is to increase maternal cardiovascular remodeling. PLGF is measured in other heart diseases, for example, chronic heart disease, myocardial infarction, post-surgical assessments. And PLGF is important in helping the heart remodel and deal with an increased workload. So the reason PLGF is there is to make the heart work harder. So although it may come from the placenta, the role of PLGF is to assess and to help heart function. So every single one of these markers that we use in the ASPRE first trimester combined preeclampsia test are all cardiovascular markers. Now, how about therapies, both prevention and management therapies of preeclampsia? Well, the most established are aspirin, calcium, statin, metformin in terms of prophylaxis. Now, where have we heard about the use of aspirin, calcium, and pravastatin before? Well, in cardiovascular disease, in helping endothelial stability. What about metformin? Well, you say metformin is a diabetic disorder disease. Yes, it is, but it also has antihypertensive properties and cardioprotective properties, and is also used in heart disease in the absence of metabolic syndrome. And therefore, all of these factors are cardiovascularly protective therapies. And of course, when a woman develops high blood pressure, the drug that we use are antihypertensives. So every single medication, both in the prevention and the management of preeclampsia, are cardiovascular drugs. And then finally, we come to the death knell for the biologist who says placenta causes preeclampsia. They say, well, when you remove the placenta, it cures preeclampsia, and ergo, it is a placental disorder. If I were being facetious, I could say, well, if you remove the heart, you also cure preeclampsia, and therefore it is a cardiac disorder. So that is a banal theory or a banal rationale for calling preeclampsia placental disease. Far more important is you understand that birth is not a cure at all. When women have preeclampsia and they give birth, there are now several studies to show that even though they may become normotensive, a significant proportion of them will continue to exhibit occult cardiovascular dysfunction. And in fact, in a 2-year study following preeclampsia, in women that we saw were normotensive, about 20 to 30% of them had occult heart dysfunction on echocardiographic analysis. What is more important is that within 10 years, about a third of women will develop chronic hypertension, and another 20 to 30% will have additional occult heart disease. And in the long run, in the next 20 to 30 years, their risk of chronic hypertension, heart failure, coronary artery disease, and even cerebral vascular disease is increased somewhere between 4 to 8-fold compared to women who did not have preeclampsia. So I say to you that removing the placenta doesn't cure the mother at all. These women are at far higher risk of having serious disorders within the next decade or so, and need very, very careful monitoring, management, and treatment after birth. So as we come to the end, I'm going to go through a couple of summary slides. Yes, we know that pre-pregnancy cardiovascular function is deranged in the women who are most likely to develop preeclampsia. And that early pregnancy cardiovascular function, as assessed in the combined screening test for preeclampsia, predisposes again to the disorder. In early and mid-pregnancy, cardiovascular dysfunction is apparent in women, much worse in the preterm group than the term group. When women present with with preeclampsia, they have overt cardiovascular dysfunction, such that 25% of the women who have preterm preeclampsia have systolic failure. And postpartum cardiovascular studies show that there is persistent postpartum cardiovascular dysfunction in these women after pregnancy. So wherever you look, wherever you are in the cycle of examining preeclampsia, there is intrinsic and intimate involvement of the cardiovascular system. In the middle is a QR code for our latest review in the expert review series in this year's American Journal of Obs and Gynae, which is open access. Please access this, and this QR code is going to be available in the next slide as well. So take it and access it. Now, for me, the most convincing, and for all disease biologists, the most convincing evidence for etiology is what's called the analogy concept. And what that means is that you draw analogies between other diseases, and that gives you a clue as to disease etiology and pathophysiology. Now, if we look at hypertensive disorders in pregnancy and diabetes in pregnancy, there are many analogies. Yes? The definition of gestational diabetes is new onset abnormal glucose levels after 20 weeks. The definition of HDP is new onset hypertension. Predisposing factors to gestational diabetes are the same as for diabetes. And we now know that the predisposing factors to preeclampsia are the same as for cardiovascular disease. What if a woman has pre-pregnancy diabetes or chronic hypertension? Well, they develop much more severe and much earlier diabetic problems, and they develop more commonly and much earlier preeclampsia in pregnancy. The diagnosis of the disorder is made from high glucose levels or high blood pressure, respectively, and we have been led to believe that the cure for both disorders is the birth of the baby. But what we now also know is that 50% of women who develop gestational diabetes are likely to develop overt diabetes in the 10 years following the birth of their baby, and that 30% of women are likely to develop hypertension following their preeclamptic episode. Now, we accept and acknowledge that gestational diabetes occurs because the maternal metabolic system is unable to deal with the glucose load of pregnancy. And it is about time that we realize that preeclampsia occurs because the maternal cardiovascular system is unable to deal with the increased cardiovascular load of pregnancy. If you look at it that way, then there's a very simplistic and a unifying hypothesis, which is what we've been looking for and requiring for many years. There is a balance, a supply and demand balance between maternal cardiovascular function and the uteroplacental cardiovascular load of pregnancy, a supply-demand relationship. If a woman has pre-existing cardiovascular dysfunction or inefficiency due to age, obesity, diabetes, hypertension, etc., then she is less likely to deal with that load in pregnancy and far more likely, therefore, to develop preeclampsia, and typically preterm and severe preeclampsia. On the other hand, she may lack these risk factors, but during the course of the pregnancy, either due to fetal macrosomia, gestational diabetes, a twin pregnancy, or a prolonged pregnancy, or because she has excessive weight gain in pregnancy, the load exceeds what is a normal supply. So a normal heart, but there is excessive demand by the uteroplacental unit. And this is a demand issue, and typically a late pregnancy preeclampsia or a twin pregnancy preeclampsia. And if you look at it this way, then there is an explanation for both preterm and preeclampsia. They do not suddenly mysteriously become two different disorders that know how many weeks you are before they develop. There's one disorder, and depending on the cause or the predisposition, it may occur either early or late. Whatever it is, poor supply, increased demand, or a combination of the two, it leads to hypoperfusion of the placenta over several weeks or days, and that leads to poor supply or a placental hypoperfusion and the outputs that we recognize. So it does not, preclude the fact that actually there is damage to the placenta. Of course there will be if you have chronic hypoperfusion. It does not preclude SFLECT and PLGF being important markers because they are released from the placenta and they're cardiovascularly active substances to help the mother try and cope with the preeclamptic disease. Thank you very much for your attention, and thank you to Philips for inviting me to give this presentation. I hope you enjoyed it, and I wish you an extremely successful ISUOG Congress.